A very good evening to everyone present here. Today we are going to be discussing management of pediatric cataract, and the class will be moderated by Akshay sir, who has recently joined us as a consultant in pediatric ophthalmology. So these are the headings under which the class will be covered. Before we get into the class, I think we should recap the last class we had on pediatric cataract. So if you could all just quickly recap under these three headings of history, examination, and investigations. How
Sir,
will
Start speaking. It's okay. It's not an exam.
sir, history of delayed developmental milestones for the patient, history of the child not following the activities going on around her, and difficulty in vision if the child is old enough.
A maternal history of any smoking, drugs, alcohol, or infections, fever during any trimester of the pregnancy,
Fever
perinatal
with
care.
rash, most importantly. Okay. Fever with rash. And another thing you would like to ask in history is any family history of cataracts. Okay. Because that straight away tells you what the etiology of the cataract is. Okay.
So usually the mother or the parent will come with the complaint of white reflex or leukocoria in the child's eye. And as correctly recalled, all of those points are included. And we have to rule out history of trauma in unilateral cataracts with preterm delivery or failure to thrive, vomiting, or any other associated syndromic features if we can see. For examination, what are we looking for?
So first on vision, the child not following light, then white reflex is what we'll see. Uh, then the that eye can be deviated, it can be in XT. Any change in IOP if the cataract is associated with an RD or something.
So IOP, yeah, that will come a little later. One of the, which is the most important, I'll say most important here, which is the most important simple test you can do with a torchlight, which will tell you some kind of prognosis about this child's cataract? Pupillary response. Okay, so if there's an RAPD, you know there's either an RD behind, or it could be a tumor, a large tumor or something. So pupillary response. Okay.
We also want to do a good slit lamp examination if possible to know the morphology of the cataract that we are dealing with. For in investigations, what are the key investigations we want to do? Okay, so just quickly, for unilateral cataracts which are not associated with systemic diseases, we want to do an ultrasound to rule out any retinal detachment, colobomas, or persistent fetal vasculature. Bilateral cataracts can also be associated with systemic or metabolic diseases, so we will do the systemic workup for those, and genetic counseling if syndromes or hereditary causes suspected. So, which cataracts do we operate on and when do we operate on them? We operate on the visually significant cataracts as the development of the immature visual system is profoundly affected by vision deprivation. And if it's long standing, then the changes may be irreversible. Also, if it is associated with strabismus, nystagmus, and unsteady fixation. Unilateral cataracts are usually operated before 6 weeks of age if caught early on, and bilateral visually significant cataracts are operated before 10 weeks of age. If they are symmetrical, then they are operated in a span of 1 to 2 weeks. If they are asymmetrical, then the denser cataract is operated upon first. For older children, we operate when visual acuity doesn't improve beyond 20 by 40, or if it has decreased further with the cataract. So children are not merely smaller adults. There are different difficulties that we have in managing a child with pediatric cataract. Preoperatively, we have a difficulty with biometry and intraocular lens power calculation. Intraoperatively, they have smaller eyes, shallower anterior chambers, lower scleral rigidity. They also have higher positive pressure, difficult capsulorrhexis, and intraoperative meiosis also poses a great difficulty. Postoperatively, they tend to have an increased inflammatory response as compared to adults. There is long term growth of the eye, and there's a myopic shift. And then we have to deal with management of aphakia and amblyopia. So, to implant or not to implant is highly debated upon, and there's no consensus on exactly when to implant or not to implant. It was said in a large study that we implant when the child's age is more than 6 months of age, but that cannot be taken as a hard and fast cutoff age. We have to look at many other factors, such as the anatomy of the eye. If it is normal, there's no associated anterior chamber dysgenesis. Gonioscopy is normal. Corneal diameter is more than 10 to 10.5 millimeters, and axial length about 17 to 19 millimeters. Then we can operate an implant in IOL even before 6 months of age. We will also look at the socioeconomic condition of the family and how well they are going to follow up post operatively. We usually don't implant, or relative contraindications are those of microphthalmia, children with recurrent uveitis, aniridia, those who have glaucoma, and obviously when there's inadequate capsular support. So if we do decide to implant an intraocular lens, how do we calculate the target refraction? So an ideal IOL power is that which prevents amblyopia in childhood and that has least possible refractive error when the child grows into an adult. So we plan for an undercorrection. Uh, or more or less, it is 20% for less than 2 years of age and 10% for over 2 years of age. Dahan's guidelines are also present, which are based on axial length. And this rule of 7 is there, in which age plus undercorrection is equal to 7. So if we have a 2-year-old, we will give them a +5 diopter intraocular lens, which equals 7. And for a 7-year-old, we'll plan a plano lens. These are the various IOL calculation formulas that we have. Here we generally use SRK2. SRKT is more commonly used for longer axial lengths. Barrett's Universal 2 formula is a more latest accurate formula in which other parameters such as AC depth are also included, and there are softwares available wherein we can enter the parameters and get the intraocular lens power. So these are the surgical steps that we follow. There's general anesthesia administration, examination, wound construction, anterior capsulorrhexis, lens aspiration, primary posterior capsulorrhexis, anterior vitrectomy, intraocular lens implantation, and wound closure. So we'll go through them one by one. First is regarding general anesthesia and examination. We need to pay really good attention to children with systemic comorbidities or those who have seizure disorders or developmental disorders, as general anesthesia itself is high risk for them. And in examination, we do this for both the eyes, in which we do check the corneal diameter. We do the intraop DBR and IOL calculation if that's not been done preoperatively. Intraocular pressure is taken, and gonioscopy and pachymetry are also carried out. And before the surgery, we need to ensure that the child doesn't have a nasolacrimal duct obstruction. So for wound construction, it can vary. If you're doing a lensectomy or a lens aspiration with intraocular lens implantation, we can do it a lensectomy from a limbal or pars plana incision. If we take the limbal incision, then the capsular bag is retained and it can be used for a secondary intraocular lens implantation. The side ports are made using MVR blade. And if we decide to do lens aspiration with intraocular lens, then we can either have a clear corneal incision or a scleral tunnel. And usually we do a 2.8 mm clear corneal tunnel. And lensectomy is more or less like preserved for cases in which we want to do like a combined retinal procedure, or so that's when we use the pars plana route as well. So we have a few. I have a video. The first video is that of a scleral tunnel in which a limited peritomy is done with Westcott scissors. Then a bipolar wet field cautery is done to achieve a bloodless field. The dimensions are measured and a scleral groove is made. Then a crescent blade is used to make the sclerocorneal tunnel. In the next video, we see that a groove is made in the cornea and a biplanar clear corneal incision is made with a keratome. Next step is the anterior capsulorrhexis, which could be called the most important step in surgery. The ideal size is 5 to 5.5 mm, and we use a centripetal force. Now, if we have poor visibility or a total cataract, we want to improve the visibility. So we'll use a trypan blue dye. In children, we need to use it for about 1 minute to stain the capsule properly. It also has a tendency to run, and there's a shallow anterior chamber and a higher positive pressure. So we want to use a high molecular weight viscoelastic substance so that it keeps the capsule down, and it also deepens the anterior chamber. And if pediatric cataracts tend to have a curved anterior surface, it also helps with that. Children have an elastic anterior capsule, so for that we can use utratas, chimeras, or microrhexis forceps. In special conditions, we may also use the vitrector, so that's called vitrectorrhexis. This is a video showing that a nick was already made with a cystitome, and then microrhexis forceps are used from the side port, in which we grasp and regrasp frequently, and we make a continuous capsulorrhexis with a centripetal force. This video shows that we've used an Otrata's forceps. It is used from the main corneal incision. This is a special case in which the anterior capsule was extremely fibrosed. So an MVR blade was used to make a nick in the capsule. Then it was tried to be cut with a scissor. And And then a vitrector was used to create the capsular opening and to aspirate the lens matter. The opening is enlarged further with the vitrector, and the scissors give a better visualization, and they open up the bag a little more. So next step is lens aspiration. The nucleus in children is usually very soft, and that's why we don't require phaco energy. We can either use the bimanual or coaxial irrigation aspiration system. Bimanual helps us gain access to 360 degrees, and subincisional cortex is subincisional lens matter is easily accessed as compared to a coaxial system. We have to ensure that all of the lens matter is removed. We also prefer to polish the posterior capsule before the posterior capsulorrhexis, as it smoothens it out, and it also decreases the chance of posterior capsular opacification. In cases of membranous or calcified cataracts, we may have to use phaco energy. We have to be really, really careful that the anterior chamber is maintained throughout the surgery, because
Pediatric patients normally have high positive pressure. So if we don't maintain the chamber, there's chances that the PC might come up and we might have a rent.
It causes pupillary meiosis because of your chamber fluctuations. Sometimes pupil in children is different, behaves differently. So if you, and that's why you should use, we don't use a Simcoe even though it's aspiratable. Why we use mechanized system? Because it keeps the chamber formed. And we use a closed chamber method even when we know that we are going to suture, or we don't do SICS or anything, because it keeps the chamber using a small incision and using a automated system allows us to keep the chamber formed. It keeps your pupil dilated, and of course, and again in that rhexis, you if you can see the surgery steps of the rhexis, it's my forces as we are, whoever is the surgeon is staring, it's always towards inside, because it tends to, because the capsule is very elastic and tends to run away in the periphery. Again, as she said, mentioned, and I came that it's probably a little convex surface, so it is used to, again the chances of extension are more if the globe is, if the rather with the capsule, if the lens is a little globular or it's in the convex. So you use a Helon-GV, which kind of flattens the anterior surface of the rhexis. It also allows you to have much more control over your, using forceps gives you more control over uh, your tearing forces which you are using. So direction of always is towards the center. You always aim for a smaller rhexis. 5 millimeter, she said, because most of the lenses which you use are 6 to 6.5 diameter of the
optic.
Optics. So you should ideally aim for covering 1 millimeter of the optic, like same case as in adults, because that gives you the best And polishing the posterior capsule, even though if you are doing a PPC, sometimes polishing is important because, again, if there are lens matter or if there is some lens fibers on the posterior capsule, it can cause irregular tearing of your PPC capsule. When you do PPC, when you are doing a posterior capsulorrhexis, it can cause a irregular tearing if there is lens fibers on the posterior capsule. So it's important to polish it. It is important to remove all the lens matter before you open up the vitreous cavity.
One question, ma'am.
Yeah.
If you're not planning an IOL implantation, then do we really need to make the main and the
No,
tunnel?
then you can do everything with the side entry. In fact, main
Only side
incision is
port.
only requirement for main incision is to put the lens. You don't need anything. You can actually do the entire surgery before you open the main. But what happens after vitrectomy is that eye becomes very soft. And then it's very difficult to make the corneal, or for that matter, even corneoscleral wound also becomes very difficult to sculpt because its eye becomes really soft. So we do it ahead of time. But otherwise, actually, you need that entry only for eye, nothing else. And if you are using uretaphosis, because that cannot go through your side port. But rest, everything else can be done. We are all aspirationists. Cataract surgeon. Okay, go ahead.
So this is a short clip showing lens aspiration with the bimanual irrigation aspiration system.
It's important that you hydro because then loosens the cortex and it becomes quite quick. If you don't do it, then sometimes it causes a lot of difficulty in aspirating. So it's important to do hydro
Hydrodissection.
Huh.
So next is our primary posterior capsulorrhexis. So posterior capsular opacification occurs 100% in children, and hence we prefer to do a primary posterior capsulorrhexis in children under the age of 8 years or those who have developmental delays or other health issues. Manual capsulorrhexis can be done with utratas, chimeras, or microrhexis forceps. For posterior capsulorrhexis, we fill the anterior chamber with viscoelastic and not the bag because we don't want to push the capsule further down, which will make it difficult to catch and make the rhexis. And also we prefer to not do the grasp regrasp. It's just grasping once and trying to finish it so that the vitreous doesn't interfere when we're doing the capsulorrhexis.
Vitreous almost never interferes because vitreous is very formed and it does not prolapse like how it happens in the adults. So PCC is relatively easier than anterior capsulorrhexis, and it's far more forgiving compared to anterior rhexis.
We try to make it smaller than the anterior
Yes,
capsulorrhexis.
so 4 millimeter at least. Anterior capsulorrhexis, yeah. It should be large enough. If you make a very small rhexis, it will close up. Younger the child, even with large PPCs, sometimes close. Traumatic cataracts, large PPCs also will close. So if you make it small, you are inviting trouble. So it should be large enough to keep the visual axis open. At the same time, it should not cause your lens to difficulty in your lens placement in the bag. So that thing is something which you have to strike a balance between.
We want to do a posterior capsulorrhexis under retroillumination to have good view of the capsule. So why do we do an anterior vitrectomy in pediatric cataracts? Does anybody know?
What happens if you leave? You can still open the capsule, and as I said, it just doesn't prolapse. Yeah, cells migrate. It provides a scaffold for cells to.
So, as rightly discussed, an intact anterior hyaloid face acts as a scaffold for lens epithelial cells to grow, and it increases the chances of visual axis occlusion. It is mandatory for infants and young children, and a limbal or a transconjunctival pars plana approach can be used. So when we are implanting the intraocular lens of choice is a single piece hydrophobic acrylic intraocular lens in the bag. Or if the posterior support is inadequate, then we can do a three-piece intraocular lens in the sulcus. Some of the techniques that are being used are an optic capture, in which the haptics of the IOL are kept in the bag, and the optic is in the rhexis margin. Bag and the lens is a little rare, in which there's a special IOL in which there's a groove in the optic and the anterior and posterior capsules are tucked into it. Piggyback IOL more or less is not used nowadays. It was used initially for nanophthalmic eyes or eyes with in which the IOL powers were really high, in which two intraocular lenses were implanted, and one was removed as the change in refraction happened. So in this, we want to inflate the bag with the high molecular weight viscoelastic and then implant the IOL, ensuring that the leading haptic and optic go under the anterior capsulorrhexis margin, and then we dial it into position in the bag. So before closing the section, we want to ensure that there is no viscoelastic left behind, as that can cause an post-operative in IOP spike. And we want to ensure that there is no vitreous in section. So we take a look at the pupil and the rhexis if there's any peaking. We always suture all the wounds in pediatric cataract. Here we use a 10-0 monofilament nylon suture, or a 10-0 vicryl may also be used. Side ports may be left unsutured in older children if they are constructed well. So how do we manage these children post-operatively? We give them we start them with topical steroids, which are started at a higher frequency and then tapered, because they tend to have a higher inflammatory reaction. Topical antibiotics, usually broad spectrum, are used for 10 to 14 days. We give them topical cycloplegics as we want to prevent any synovial formation, and oral steroids are only used in special cases.
More than synovial formation does not occur if there is no inflammation. But basically, to keep the ciliary spasm at bay, and child is more comfortable if the patient is on cycloplegic because it prevents ciliary spasm. And of course, in uveitic eyes and all, it keeps the pupil mobile by giving little.
Now, for the children that we've left aphakic, how can we manage them? We can use spectacles or contact lenses. Spectacles are used for bilateral aphakia. Children adapt well to spectacles, but they have poor cosmesis. They are heavier. They tend to slide down the face, and that's why not preferred. Contact lenses can be used for unilateral and bilateral.
They preferred because we live in India. Okay, most of our patients neither have access to contact lenses nor they want to use it.
Affordability.
So spectacles work very well in my experience in bilateral cataract. It does not cause poor cosmesis or anything. Just remove that point from completely. We are not bothered about cosmesis in children. Okay.
Okay.
We are more bothered about keeping the visual axis open and refraction, whatever the correction in place. So don't say things like that which have no value in a scientific class.
Okay.
Cosmesis is not our neither the goal nor a factor to be considered. So they work, yes. Only thing which is a little worrying about with spectacles is that they do increase slightly more increased incidence of strabismus with spectacles, and you probably need to keep that thing well. And children adapt well to spectacles; they do very well. Only thing which you have to pay a little bit of attention to doctors is that fit should be correct because these spectacles are really heavy. So your material and your choice of frame, lot of time children don't want to wear glasses because not because they don't want to wear glasses but because the fit is so poor, and it is heavy, and the nose clip here is too small for them to support. A lot of children, infants whom you are going to leave a fake cake are going to have no nose bone here to support the spectacles. So you should have a frame which gives you adequate support on the nose, and that is important. That fit is important rather than the cosmesis or anything else. And it also is slightly more associated with a little bit more incidence of nystagmus if you are leaving the children a fake cake.
We can prescribe contact lenses for unilateral or bilateral aphakia, but they are difficult to insert and they are costly. They give better optical correction, but the risk of infection and intolerance is high, especially in developing countries like ours. Then management of pseudophakia, we've already undercorrected the child. We want to give spectacles immediately after surgery. For young infants, we can give single vision glasses and bifocals and progressive for older age groups. In
Single vision glasses are appropriate for if you are giving in a 6-month-old child, if you are giving a you have to give whatever is appropriate for near or intermediate distance. So if they are very small kids, like say under 6 months, you would give them a single vision glass with full near correction. But same child at the age of 1.5, when they are a little bit toddlers and they are a little older, you can add only 1.5 to their distance correction and give that as single vision glasses. I usually start them on bifocals as they start their preschool. Then you can start them on bifocals or even progressives, but progressives are again expensive and these require frequent changing. So you need not push progressive glasses unless children are really older, say 6 years and above.
For amblyopia management, we need to do amblyopia management right after surgery in unilateral cases. For bilateral cases, we will look at if they have a fixation preference, or if the best corrected visual acuity is less, then we will give them amblyopia management. So what are the complications that we can have? That is, as discussed, post-operative inflammation. Then we can have posterior capsular opacification or secondary membranes, which is usually a very common cause for repeated surgery or a repeated surgical intervention in children. And we've already done the primary posterior capsulorrhexis and anterior vitrectomy. In older children, if we've left it intact, we can do an NDA capsulotomy. Pupillary capture or IOL decentration can occur, and it is more commonly seen with IOLs that are implanted in the sulcus. So, in the bag, implantation gives us better centration and lesser chances of decentration. Children can also have glaucoma. So, the incidence is higher in children who are operated earlier in life. Pachymetry and
IOL does not correlate well with glaucoma, means it's neutral. Glaucoma incidence or glaucoma possibility is higher in children who were younger at the time of surgery, irrespective of whether you put the IOL or not.
So a baseline pachymetry and corrected IOP needs to be recorded. If there is a myopic shift or increase in axial length,
We do not consider pachymetry or corrected IOP. If the pressures are high, you will treat it. That is what the new glaucoma, World Glaucoma Council guideline says, that in children you cannot or you need not correct for the corneal thickness because it is not right in children. A lot of them will have thicker corneas post surgery, and while so the whole thing needs to be kept in mind: myopic shift, optic disc, as well as IOP. So when you make the diagnosis of IOP, don't explain away pressures of 23 saying corneal thickness is 600. Corneal thickness will be 600. But if the patient's myopic shift has happened, you need not consider that pachymetry into your equation at all. You really look at optic nerve also. This needs to be checked in every postoperative visit which patient makes throughout their lifetime. So if you're operating a child at 6 months, his care lasts for 6 months to 80 years, whatever time he is going to. So it should be in every follow-up, IOP to be recorded, disc evaluation to be done, and refraction to be done, because without that, you really can't comment on any child. In fact, the surgery is the easiest step in management of pediatric cataracts. That is something which is done in 20 minutes in good, experienced hands. It takes me exactly from conjunctiva to conjunctiva 25 minutes, no more, to do everything whatever she said. But this takes me 20 minutes with every child. And this is more important because all my excellent video can be undone within 6 months. If the pressures are high or retina detaches, if I don't see, child will go. So it's important to consider that surgery is just only the first step on a very, very long road. And this must be emphasized on the patient, to the parents also, when you are advising surgery. You're just starting the process, you're not ending it. This is not the treatment. Treatment will go on beyond that.
so the glaucoma can be managed medically or later on.
Luckily for glaucoma, which happens after cataract surgery in children, is very amenable to treatment. and medical treatment. And often a lot of these children do not require surgery, that considering if you are looking at primary congenital glaucoma, where the treatment of choice or first step of treatment is actually surgery, these children can be managed medically quite well for years.
That's thank
No
you.
other complication. PAO, visual axis opacification can happen. Also no complication. Postoperative. Retinal
Retinal
detachments,
complication.
breaks are very common. These are all long-term complications. So when you're talking about complications, you should probably
Short-term,
classify as immediate postoperative and long-term. So glaucoma can be an immediate postoperative
and a long
complication as
term.
well as a long-term complication.
Ma'am, the choice of instrument for capsulorrhexis is based on any change in the capsulorrhexis or the surgeon's
No, no.
preference per
Actually,
se?
it is surgeon preference. Whatever works in your hand, you should use it. I trained in Utrata, so I always use Utrata. But a lot of my younger colleagues, the important thing is get that rhexis. And advantage of microcapsule of vitrector is that you need not open the, for Utrata forceps, you need a slightly larger incision. So for smaller incision, rest everything can be done through your side entry 1 millimeter incision. But for Utrata, you need that 2 millimeter or 2.5, whatever you incision to use it comfortably. In fact, a lot of people now use even vitrector to do both and to create both anterior and posterior axis. And a lot of surgeons often put the IOL first, then go underneath the IOL and do PPC and anterior vitrectomy after implanting the IOL also. Nothing wrong in that. Whatever works in your hand, you should do it. Vitrectomy should be complete, should not have strands here, there. Pupillary opening, posterior capsular opening should be adequate. How you do it is up to you. So I have done it with vitrector, but yeah, this works best because you have manual is the strongest edges. It is never going to extend. You can do whatever you want to do. If you have done it a manual continuous curvilinear capsulorrhexis, it will not extend in any circumstance. While as with vitrector, there is always a chance that there may be a tag, and yeah, it is faster, but there may be a tag when you are inserting the IOL. If the bag is small, you do a little bit manipulation, it can extend. The edges are not as strong as, even I think flax edges are not as strong as manual CCC. There is very little literature on flax in children, but even that probably is inferior as far as. Has anybody heard about Zepto? Zepto laser. Zepto is also being used for
Making the rexis,
making the
capsulorrhexis.
anterior capsulorrhexis with reportedly good results and fairly safe edges. But the equipment is bulky, requires a little bit of time and little bit of learning curve. But there is a small paper from Ramesh Kekunya's group, and they have shown that fairly stable edges. So when you are looking at options, the newer thing, you should also keep that Zepto laser, or it can also be used for creating anterior capsulorrhexis. It's not that effective for posterior capsulorrhexis, but anterior capsulorrhexis is fairly safe with Zepto laser. Any other questions? Yes, if it is nylon, then as soon as suture becomes loose, you must remove it. Loose suture has no role in children. If suture is loose, even if it is 1 week later, you have to remove it. If you are not secure about the wound, put re-suture it. But having a loose suture is just providing a entry for the organism. As long as suture is tight, there is no gap. But once the suture is there, it's a kind of a tunnel there, right, for bacteria to go inside. The loose suture, there is no time period that you have to remove it now or then. If suture is loose after 1 week after surgery, remove it. It's not doing anything for that child. If you think that no, my wound is not secure, take another suture, but remove the one which is loose. And in children, sutures become fairly loose very quickly. if you are using something like Vicryl, which will get absorbed over a period of time. But that also, if you see loose collecting, go ahead and remove it. So there is no role for any loose suture to be there at any. It has no business to be there. If it's a corneal wound, all the more serious. Corneoscleral wound, sometimes you can get away with little loose sutures, or because sutures are covered under the conjunctiva and there is no direct entry. But if it's a corneal wound, sutures have to be watched and any loose sutures to be removed as quickly as possible.
So in the surgical steps that you were covering, one more important thing that we can do in children, we do it in adults also, is to actually polish the capsular bag. So you can switch to the PC polish mode and actually clean off those lenticular epithelial cells. You can actually see them under retroillumination. That also helps to reduce some amount of visual axis opacification later on.
No, ma'am, I've covered it only in the handout, actually.
And in short, has not proved that IOLs did better than contact lenses in unilateral cataracts, or for that matter, even in bilateral cataracts. So, what started like anecdotally that IOLs will be really magically better than Aphakia, evidence did not point towards that. Of course, study has its own flaws, and there are problems with the methodology of that study in many ways, but at least you must read 3 or 4 publications which have come out of. There are, I think, more than 50 publications which are there with the infant aphakia treatment study. But you should look at 1-year outcomes, you should look at 5-year outcomes, you should know the resurgery rates between the two, because they found 5 times more resurgery rate with children who had IOLs. They did not find any difference in glaucoma rates. Visual outcomes at 1 year as well as at 5 years were similar in both the groups. So these are the things which you should know, because it will be asked. So when it come, and that is a study which is very often quoted. You should also look at whatever has been done in Indian population. There are excellent publications which have come out from both PGI Chandigarh. Some of them very good. I think you should read about that. He has covered infant aphakia treatment, but I want you to look at 1-year outcome, 5-year outcome, glaucoma outcomes, surgery rates, because these are something which you must know as exam going BGs, or even if you apply for interviews or fellowships anywhere. I think this is something. If anybody who is interested in pediatrics, this question will questions. Anyone has any doubts? All clear?
No, ma'am, I don't think so. Yes, ma'am. Thank you, ma'am. Thank you, sir.